Welcome to Rural Health Today. I'm JJ Hodshire, President and Chief Executive Officer of Hillsdale Hospital, and this is a podcast where we connect you, the listener, to what really matters the most in rural health. And I'm thrilled to be in the studio with today's special guest, a great friend of mine, a colleague, someone that I've got to know quite well over the last several years in my role on the Michigan Health and Hospital Association Board. It is my privilege to once again welcome to our listeners across the country, Laura Oppel, who is the Executive Vice President of Government Relations and Public Policy at the Michigan Health and Hospital Association, oftentimes referred to as the MHA. And first of all, Laura, I want to welcome you back, but I also want to congratulate you because you were recently promoted, well-deserved. I could not think of anyone better, and I know our colleagues at MHA are going to listen to this, but anyone better than you to have received that nod to be our vice president of the MHA, and not only the vice president, but the executive vice president, leading several things. But for our listeners who may not know you, I would like for you just to share a little bit about your background. I know you've done it before, but this is a new podcast. And give us a little bit overview of what do you do at the MHA on a given day?
Well, I have been blessed my entire career that really almost no 2 days have been alike. And that has been incredibly rewarding and stimulating. Before I was with the MHA, I worked in our state legislature here in Michigan as a policy person. And I specialized initially in insurance and then kind of grew into appropriations, including things like Medicaid. I had stints doing a lot of work on retirement and commerce, banking, whatever. I got a great experience there. And it was time for me to look for the next thing, as term limits in Michigan were so short and leadership turned over. And I landed at the MHA. It was a few years ago. I'll tell you how long ago it was. My best friend found the ad in the newspaper. And she's
in the
newspaper, hard copy newspaper, not electronic. And she said, you should apply for this job. And I did know some people at MHA already. I'd been working with them on other boards and issues. And I got the job, and I've been here ever since. And now I oversee the efforts that we do in terms of advocacy, meaning state and federal lobbying, in terms of communications, member relations work, like alerts to members about what they need to be saying in terms of advocacy, but also responding to the media. We have a finance division, and those are the folks that are responsible for maximizing our opportunities for funding without doing anything wrong. And then we also have a policy division, and those folks are tasked kind of with things at both ends of the spectrum. We have this problem, how do we fix it? And this became a new regulation, law, guidance, whatever. How do we help implement it? How do we help our members implement it? Michigan, the MHA, as you call us, Michigan Health and Hospital Association, we represent every acute care hospital in our state. Pretty much, if I tell people if they have an emergency department, they're my member. And we also represent a large number of our behavioral health hospitals, inpatient psychiatric hospitals and units. We have some rehab hospitals, and we have long-term acute care hospitals in our membership. So altogether, I think we claim about 160, quote, hospital members.
And I think it's worth noting, we did a series. We did a tour around the country. We interviewed every state association president and or in conjunction with that, their rural health association, their whether it's connected to the state universities or whatever it was. And interestingly, Laura, we were, Michigan at the time, the only association that had 100% participation from all of the member hospitals in that respective state. And that's not easy to do. And I believe it, I can say from firsthand experience, it's the relationship that is built from your team. It's amazing to have, let's say, Sam Watson early on in my career drive to Hillsdale and field engagement. Dr. Roth, whoever it is that represents MHA, physically boots on the ground in those respective hospitals across the state. I think that's a unique position that MHA has placed itself in compared to peer organizations. Would you agree with that?
Well, I don't know enough about those others. I haven't had the same opportunity that you have to kind of experience, their conversation that way. But what I would say is that comes from the top. Our CEO, Brian Peters, is hugely invested in making sure that we have member unity, and he spent an immense amount of his time on those relationships, and we get that signal, and it's what drives us to, as the leadership staff, to do the same. In terms of, I think you've seen Jason Jorkowski, who's my finance VP, and John Karasinski, who is our comms VP. I think they've both been at your hospital in the last year.
Yeah, absolutely.
Who leads our advocacy effort? He's been there. We don't just go to Hillsdale either. I mean,
no.
Wednesday I was in Pigeon, which I'll use the hand. Where's Pigeon? Where's Pigeon? Pigeon is kind of like here. It's not all the top of the thumb. It's like here. And it's a very small place with a 15-bed critical access hospital, but it's a solidly populated community, and it's a place where they really need a hospital, and they also have a long-term care unit. So we go all over the state, and but the most important thing we do, I think, is work in the state legislature and in the Congress to minimize the challenges for all hospitals, including our rural hospitals, and maximizing the opportunities.
Yeah, so let's dive into that a little bit, Laura, if we could. Mm-hmm. One of the, I'm going to say, hallmarks of MHA is bridging relationships between member hospitals and, at times, their elected representatives. It's amazing to me how many times that a hospital CEO does not have a relationship, it's across the country, with their U.S. rep or senator. And what's really remarkable at MHA is that you all facilitate opportunities, whether they're forums, whether it is annual meeting, whatever it is, you bring these folks together. Most, I think, notably is the work that you do in bringing groups to both Lansing and Washington. I know whether it's from the inauguration, regardless of what the party affiliation is, we have representation there. We have representation in national recognition days in Washington. We are a team leads that initiative in both Lansing and Washington. But why don't you speak to that? Speak to why you're doing that type of work. One might say, shouldn't the MHA be getting money for hospitals? Well, you do that too, which we'll talk about in a minute. But the advocacy piece is huge.
Right.
You want to dive into that?
Yeah. So you might think of us, for people that are not so familiar with what a, quote, trade association is, which is exactly what MHA is. We represent the trade of hospital-based healthcare and health systems. You might think of us as the Chamber of Commerce for hospitals. So while the Small Business Association of Michigan represents small businesses, and the Michigan Chamber represents dozens, if not hundreds of businesses, we represent the hospital part of our communities. And we do that primarily, really some of the major work of the association is talking to your lawmakers and your members of state lawmakers and members of Congress to help them understand not just what you need, but what you are, what you're doing. We work as much on literacy about hospitals and our broader health systems as we do on the advocacy, which is going to the Congress and saying either please do this or please don't do this or do more of this thing. This is working really well. We need to enhance it. This isn't working well at all. We need to change it. So we're not always going just to ask for funding. There's a lot of, there's a huge amount of hospital regulation. So we talk about that too. And we don't just use the Congress as our sounding board. We have a lot of things happen at the federal level in terms of regulation. And we do all kinds of commenting on that kind of thing. So why, how did we get there? Why are we doing, we've always been a advocacy organization in terms of state legislative work. The MHA has a long history of being very effective that way. uh, going back to, for example, the work on medical liability and changing
Yes.
laws to be more effective in terms of making sure that people get compensated when they need to be, but that it's not a lottery system and becoming overly expensive. And we also, about 20 years ago or so, kind of recognized that we had a greater responsibility in talking to our members of Congress and getting our membership engaged with them the same way we do with state lawmakers. We were doing kind of taking whatever the American Hospital Association sent out and then circulating that, but we weren't doing a whole lot of regular engagement with our members of Congress, especially in DC, and working to get them in the hospitals and things like that. And I really, it's not funny, haha, but it's kind of funny, odd.
Mm-hmm.
We would get these faxes, and it would be like, send out the fax, and that was kind of all we would do.
Yeah.
We really ought to be doing better than this. And I kind of just started doing it. And then Brian said, well, we'll call you that. You can be, VP for federal advocacy or something. I was like, okay. So I kind of made up my job. And years later, here we are.
That's incredible. So before we dive into Michigan a little bit, I do want to talk about the landscape in Washington. I had the opportunity, and you were at this meeting several months ago with the president of the AHA in Lansing. We had dinner with him that night, and he shared something very remarkable. And I'm going to paraphrase him. Basically, in all of his years, and he has many in DC, he's never seen government so transactional. And you have, I would say, the second most experience of those that I know that go to Washington. Describe the climate for Washington as it relates to healthcare.
Right. Well, I think that when it comes to healthcare, one of the things we've actually kind of been boxed out of the transactions. There is a lot of, it's very much like, if you're on our side, we are here for you. And if you're not, we're not. But healthcare was kind of identified early in this congressional term as being a place where there was an opportunity to make dramatic change, because unlike probably, from 2019 and before, hospitals were kind of, I would say, universally revered. Mm-hmm. And there have been a number of efforts to criticize hospitals, especially not-for-profit hospitals, and what their performance is and those kinds of things. And I think that in this current environment, that undermining of the hospital sector allowed us to be targeted in the work that they did in the Congress. Mm-hmm. And that is not something that I've experienced before. Yeah. I think a lot of people in Michigan, and I'm sure this would be true if we polled in other states, they might have issues with the healthcare system, but they're very much in support of their local hospital. But even that message didn't resonate as things were moving forward in the Congress, and that resulted in this, I think, unprecedented cut to hospital financing. Mm-hmm. And I want to make it clear that hospitals don't exist just to get money. Hospitals exist to take care of people, but without those finances, that becomes difficult and progresses to impossible.
That's right. So as we shift the conversation from the federal perspective, let's kind of go to the state. And the way that we make the transition is because back in April, a lot of my colleagues, in fact, I was just looking last night, April 13th, I gave an all hospital, all medical staff video address. It was about 18 minutes in length, and I sent it out and to my board of trustees and just had the dialogue that things were not looking good in Washington, that we needed to lobby Congress. A lot of people came back at me and said things like, JJ, this is just a process. This isn't going to be where it lands. This is just the conversation. And Laura, it happened. And sadly, today, I'm being told the same thing by my colleagues about Michigan. JJ, this is just step one. There is a huge risk, we've talked about it, of what happened in Washington right under our noses when we all just said, oh, no, they would never devastate healthcare like that. is happening in Michigan. So talk to us about what we're facing right now in Michigan as it relates to healthcare budget.
Let me preface this by giving a little extra detail about the Michigan situation that your listeners might be like, what? But it's critical. So Michigan has been extremely parsimonious with its use of general fund dollars to support Medicaid funding. And Medicaid has grown from being about 10% of Michigan's population covered with that program to probably more than 25%. And yet the general fund investment from the state of Michigan has stayed about the same. Now, how did we do that? How did we go from 1 million covered lives to 2.5 million covered lives without substantially increasing or marginally increasing the cost to the state's general fund? Well, we did that because we don't use income tax revenue or sales tax revenue or corporate taxes, business taxes for that new level of expenditure, the funding necessary to take care of a new 1.5 million people. Hospitals pay a tax to support Medicaid. And we have grown that program over time to be hundreds of millions of dollars, but it relieves the pressure on the state's general fund, and it keeps hospitals able to pay for the services that are necessary for people who come to your door. It's a big deal. It's a very big deal to use that program because it keeps the burden off of state taxpayers, and yet we are able to keep taking care of all of these folks who need services. And in a recent House-passed state budget, they moved money around in a way that a very substantial portion of that special financing was endangered. We estimate that roughly 60% of that money would go for salaries, labor, and hourly and wages and salaries. And if we were to actually lose this $2.5 billion that was moved out of the hospital services and therapy line item, it could cost as many as 20,000 jobs in Michigan, specifically in hospitals. And we are all told, don't worry, we're going to change this. That was more of a procedural vote. We had to make our point. I want to also point out to your audience, this didn't save the state any general fund because, again, it's all funded with these taxes that hospitals pay, again, to keep the burden off of state taxpayers and yet deliver services. And luckily, we perceive that the state Senate will reject this concept. And we are, I think, also confident that the governor would refuse to sign something that came to her this way. But I don't even want to get that far.
I don't either.
We want to make sure that we stop this and it doesn't proceed any further than this House-passed version that, as the Senate and House negotiate and the governor's office is there as well, that we just come right off the table, and we should, because, again, there's no general fund dollars saved in this tactic that the House-passed budget uses. It's saying whatever program we're using to generate the allowable federal match, we're just not going to do it as much as we could and as much as we have been. And the other thing about what was so disappointing is, in this budget cycle, hospitals have really not asked for any new money. This would have been a continuation budget for hospitals if the House had simply left it alone. And we're actually satisfied with that. So, it's a little puzzling. It's certainly disappointing. And I want to applaud you, JJ, for all of the work that you've done to point this out to the public. We also have, between using our online legislative action center and a special mechanism that we do to generate calls into lawmakers' offices, we're over 2,000 contacts to certain members of the House of Representatives to help them understand how strong the opposition is to the strategy that they used.
And that's powerful. It's one thing that the association goes after or tries to influence or educate the legislative body, but that only goes so far. Where it comes into play is the constituents that live in their backyard, that will go to their fundraisers that they see in church. That's where the voice needs to be lifted up. And you've been great as an organization to say, get this out to your board, get this out to your doctors, get this out to your community. And you have done a phenomenal job of it. But let's say that, this is a national podcast. Someone's listening from Texas, from Iowa, other places. What advice would you give that CEO, that C-suite person who wants to speak up and express their concerns with funding cuts, but feels hesitant because of this political climate that we're living in? I want to tell you that, I came out strong, as you know. I had my own friend, my own congressman friend, who had a differing opinion than mine and still does. And, comments were made about my position. And the end of the day, it's not easy because these are people that you may have been friends with, or you may say in today's political climate, is it worth it? But please give us the why.
What I would do in terms of encouraging people is we have several sayings at the MHA, and one of them is we can't make friends when we need them. So the first thing is, if you are a CEO, perhaps you're new, you've just taken on a new role and it's in an area that it's in a different state or something, invest heavily in becoming familiar with and cordial with, even if you're not going to be, someone's best friend, but meet them, introduce yourself, talk to your member of Congress, talk to both of your U.S. senators, figure out a way to do that. Sometimes finding them in D.C. is nearly impossible because they are really slammed. Go to their district office, go to their community town halls, step up and introduce yourself, and make sure that you have that acquaintanceship so that when you need to start making your point, you're not introducing yourself and saying, "Hi, I'm Laura, and nice to meet you, and here's what I need." Make friends before you need them. I think pretty much everybody knows that, but we remind ourselves of that every day. So this is, I think just that's how fundamental it is. And then the other thing I would say is you can't give up on delivering the message, but I think we all know that there are ways to be firm without being confrontational, or even in situations where people are looking for a confrontation. We have to figure out how to just really stick to the facts because they are in our favor. We hear a lot right now about not-for-profit hospitals, but all hospitals, including investor-owned. You guys have too much money. In Michigan, we heard the message from some House staffers. We know hospitals are greedy and they're printing money.
Yep.
In 2023, the estimate of all of the state funding, federal funding supported with hospital taxes, all together, if you added that all together and aggregated it, it was $800 million less than what it cost to take care of the Medicaid population.
Yeah.
And that's not printing money. And I got to tell you that a lot of people ask me, well, doesn't that just get switched over to the business community and they pay it in their premiums? I don't know. How long is your contract with Blue Cross Blue Shield of Michigan? Do you need to go like 3 years at a time?
It's 3 years, yeah.
And if something bad hits, like a couple of years ago when we had a terrible problem with access to certain chemotherapy drugs and the price increased by 50 times, did anybody from one of your commercial payers call up and say, in the middle of our contract here, let us adjust that and pay you? We would let us step in and help you out with that.
Yeah, not happening.
Not happening. So we need to let people know that it's not something that you can kind of add up at the end of the day. Here's what Medicare was short. Here's what Medicaid was short. Here's the uncompensated care. And then we just say that Blue Cross Blue Shield of Michigan or Health Alliance Plan or Priority Health, you guys just pay that much. I'm just adding that to the bottom of your bill. It doesn't work that way. So making all of those things very clear and then going into the conversation about, there was more than elimination of waste, fraud, and abuse in what came out of the OBA, which the Big Bill Act. It's real cuts to real hospital financing that takes care of real patients and pays real staff, nurses, physicians, et cetera, to take care of those patients.
Absolutely. So let me ask this question. If the CEO is positioned in any other state than Michigan, what would you recommend for them to leverage their relationship with their state association? Because I think you would submit that this shouldn't be done alone, right? I mean, should I, as an independent hospital sitting in Nebraska, call up and say I'm flying to Washington without at least notifying their association? Talk to us about the relationship.
Yeah, I mean, I want to make sure that people don't think that we're suggesting that they have permission, that they be asking for permission.
Right.
Coordinating really helps with the impact that you can make because the sum is greater than the parts. And I read a book many, many years ago by a guy who was kind of, I don't know, call it PR, marketing, branding, whatever. And his point was, whenever you do something, you should have 3 steps that are already planned. So for example, don't do a press release and then just let everything sit there. If you're planning to make a big announcement about something, how are you following that up at least 3 times? And he gave the example of Lionel Richie in 1984 played the closing ceremonies of the Los Angeles Olympics, the International Olympics in LA, and the audience was 1 billion people. But he had nothing ready to go to follow up. He didn't have an album ready. He didn't have a tour ready. And it kind of just like, my gosh, you're in front of 1 billion people and it fell like a thud. So think about that in terms of, if you let your association know, I've really got to get to DC and talk to my member of Congress, and even I really need to talk to their health staffer, because that staffer is really very responsible for that issue. Let your association know, because they might say, well, I'm going the week before or I'm going the week after. Tell me what happened, and
or I'm going to be out there at the same time.
And then, they probably will also say to you, and if it's that big a deal, while you're out there, ask them if you can get them into your hospital to take a look around in the next 2 months, in the next work period. So now you got your 3. You went there and talked to them, your association backed you up, and you've scheduled a visit. And I think that's the kind of thing. And then, or the association might say, well, we do the annual Washington meeting that the American Hospital Association engages in. Why don't you come with us there? We do Hill visits and we organize all of them, and, go with us. A lot of people are in systems now. I know Hillsdale is still one of our remarkably independent organizations, but a lot of people are in systems, and your system probably is doing a lot of this work too, and also probably in conjunction with your both state and national associations.
Yeah, and I think it's critically important in that relationship building. So let's focus on one last thing as we close out the podcast today. And I guess because we are rural health strong, rural health today, I do want to close on focusing on our rural hospitals across the country. We know since 2010, over 150 hospitals have closed in this country, all rural. KFF News has reported, 800 hospitals at risk of closing between now and 2032, when the full fruition of that One Big Beautiful Bill is implemented. And their numbers are even staggering from nonpartisan organizations that have done research. I had just recently on this podcast, Scott Becker, he shared with us some of the work that his team has done to dig into what are those numbers. They're very, very shocking. And 200 hospitals at risk of closing immediately, 3 in Michigan at immediate closure. Just this week, it was announced, or maybe at the end of last week, that a hospital up north in Michigan was going to shutter their services for obstetrics. We're hearing that across the country. So I guess the question for you is, rural hospitals they're dying around this country. And the answer is not mergers and acquisitions, in my opinion. The opportunity is, how do hospitals remain independent and strong in rural in their community, provide the full continuum of care. So in your mind, you work with all of the big and the little and what we would call ourselves the mid-vitals hospitals. And so I want you to put on your cap for rural hospitals today as we close this out. What needs to happen at the federal level if we want to make rural hospital systems, rural hospitals and communities like mine sustainable into the future? And then I guess relate to that in your mind, the work you've done for decades. What is the MHA doing to help promote that?
So I want to just list off a couple of, the folks who are listening that aren't in the healthcare sector might be wondering, well, why is it so hard? And I've been spending some time with a national organization called the Advisory Board, and they have produced some good information. And one of the things that they have pointed out, a couple things. Number one, we're not seeing any growth in commercial insurance coverage. So that has traditionally been the most effective at covering the cost of care and helping people actually have a little bit of a margin to address their increased costs, like new nursing salaries and capital improvements and equipment and stuff like that. So that's shrinking, and we're becoming more and more dependent on our publicly funded Medicare and Medicaid, but privately administered. Medicaid, primarily in Michigan, is through Medicaid contracted Medicaid managed care organizations. Build on top of that, so there's lots of cost pressures for those insurers. We have a smaller, sicker, younger generation. So the folks that are coming up are not the healthy young population that we think of traditionally. And we are coupling that with a very large aging baby boomer population. So we have people that are much more sick that are using hospital services. So you're getting more government funded payment at the same time that you're having people with higher acuity, deeper needs. And your populations in rural areas are those older populations or people that, don't have commercial coverage. And so you've got it coming at you from both ends in a way that I think that our urban areas are not yet experiencing to the same degree. I don't want to make it sound like they're getting off easy. And I make it sound like they're never going to face this at this degree, but you're kind of like the leading edge of this curve. And so I think that we have two needs. One, I'm going to go back to my literacy category. Build the understanding of your policymakers, state lawmakers, members of Congress, U.S. senators, or business leaders, whatever. Build their understanding of what you are facing. And we ask people to, like, if you're doing a hospital tour, we know that you'd love to show them the new mammography machine that your volunteers helped you or your foundation purchased. Also, please show them the 6 people that you had to hire just to do Medicare, Medicaid, and commercial insurance prior authorization.
Yeah, that's true.
Show them that cubicle farm of people just on the phone doing no patient care whatsoever. Show them the labor and delivery unit that you haven't been able to upgrade because those payments are so low. So we need that literacy, and then we need to figure out a way to address, and I will be the first to say that I've got lots of ideas, but nothing has really gelled yet, but figure out a way to address the fact that to be a hospital includes fixed costs that you're not going to get with volume because your population is small. It's going to cost X to run your ED, right? And it's going to cost that on a daily basis or a weekly basis, whether you have 100 people come through that week or 1,000 people. When our populations are small and not growing, you might be on that more, that skinnier edge. And so you can't spread it over the volume. We have to look at ourselves and say, do we want these anchor institutions that make a community what it is? Do we want to keep them? Yes, we do. Well, then this is the way the financing has to change, because you can't just say, as long as people keep showing up, we will have the resources that we need. We need to that we have critical services that guarantee access for people who are, like I already mentioned, are already getting sick younger and are aging, that aging population is growing. If we want that ED there, if we want your inpatient services, if we want businesses to come someplace where people can deliver their babies as young families and, grow their employee base, we're going to have to do a different way of investing in hospitals and rural hospitals specifically.
Absolutely. Well, Laura, it's always great to have you on the podcast. I remember my first few MHA board meetings. I had the privilege of sitting there and I looked around the table, and, there were legends and incredibly smart and amazing people like Bob Riney around the table, who I really looked up to, just an incredible guy. And then I look out in the audience and I had a chance to see you, and you spoke, and I thought, she's really good. This gal is talented. She's knowledgeable. And I think the experience in Lansing has paid off tremendously for us at the MHA for you to leverage those positions. It is a little bit sad that, term limits have kind of changed a lot of those deep personal relationships we've had. But what's remarkable is that you and your team who you lead build those relationships within weeks, if not, just months of a new representative or senator coming on board. So I want to thank you for your wisdom, for your insight, for your knowledge. It is truly a pleasure to work with you. I look forward to the future. And in that wisdom, I like to close the podcast out with what's called a rule recommendation. So I hear from CEOs across this country about this podcast, and they'll, give me praise about a particular subject that we tackled or a guest that we had on. And, a lot of them end their emails with, JJ, what would you recommend for this? And, our hospital's struggling in this area. What would you recommend that we do? And it is a great privilege for me to be able to do that. And I thought, you know what? Instead of me being the voice of that, let our guest do that. So if someone is listening to this in a state far removed from Michigan, what is a rule recommendation that you'd have for a new young leader? Maybe it's someone who's really struggling right now as a leader because we have to balance all these proposed cuts, the cuts that are coming, all of the changes that are happening, recruitment, retention, you name it, we're tackling it. What piece of advice from your seat that you've been in for decades in healthcare, what advice would you give them to study?
Yeah, so this is actually something that I think we've all learned within the last 5 years. I would connect with your colleagues because I think there is so much support within the rural hospital CEO community. And, your state association probably has a rural council. If for some reason, engage with that, pay, just do whatever you can to, sometimes it's virtual meetings, sometimes they're in person. But I'm thinking about the pandemic, and there were many, many constituency groups that we convened during that because everybody had a problem. The supply people had a problem, and the lab people had a problem, and the chief medical officers had a problem, and the infectious disease specialists had a problem. And in many of those conversations where we would convene people, and those, of course, were all virtual, I felt like people were presenting me with problems that I was never able to fix more than like 10%. But an awful lot of what actually was effective about gathering people together was the fact that they could share with each other what's going on there, how are you managing it, what are you thinking you'll do, here's what I'd like to do, but I know I can't get it done, those kinds of things. I think there was so much value in people sharing their experiences and understanding they weren't alone, even sometimes coming up with solutions together. I would really, reach out to your colleagues. I know there's a whole lot about, competition and all of that kind of stuff. When they're all in a room together, those small rural CEOs are, they share, they're interested, they're connecting. And that would be like maybe the first thing I would do if I was a new person and feeling like I need some support here and I'm not really, and chances are that somebody else is also very new and trying to figure it out. And there also are people in the room who have been doing it for 30 years and can share their history. And so that would be my first thing. Second thing would be, I guess I said, if there's a small rural council of some sort through your state association, do everything you can to get engaged there.
Absolutely. Lastly, I'll say, I was with President Bush about 8 years ago in Chicago, and he was getting pressed pretty hard about, Iraq war. And finally, at one point, I think he just got fed up. He says, stop it. Now listen. He goes, history is going to judge me, not you. And it was a question posed by one of the media that were there that day. He said, history will judge me. And, you have your opinions. I have the reasons why I did what I did in the conflict. You weren't there in my seat, essentially. I'm paraphrasing, of course. But the one thing I do remember is he said, history will judge me. And as I look at the issues we're facing right now in Washington, I think the fight that we have been engaged in, we're on the right side of history. Mm-hmm. I think, we are on the right side. Yeah. And others will disagree with me and say they're on the right side. Mm-hmm. And this is my party, historically speaking. But I'm going to tell you, they're not on the right side of history on this one. I can affirm to you that looking at the faces of Medicaid, looking at myself growing up on Medicaid, looking at the faces around my community, my own, friends who are pastors who come in here, we're on the right side. We're doing what's right. And Laura, you're doing what's right. So continue
Thank you.
to keep up the fight and the engagement, and may God bless the work you and the team are doing at MHA. And thanks for being a voice for us. We appreciate it.
Well, first of all, I appreciate your kind words about me personally, but we also very much appreciate your expressions of gratitude. It is, I cannot tell you how rewarded people feel when they hear stuff like that. So thank you.
Well, thank you for joining us today. It's always a pleasure to have you on. And thank you to our listeners for tuning in to Rural Health Today. Catch our next segment, Rural Health News, to stay up to date on the current state of rural health every Monday, wherever you get your podcasts. Don't forget to check out the latest updates and resources from Rural Health Today at ruralhealthtoday.com, and make sure that you subscribe to the show so that you never miss an episode just like this one. Until next time, remember the power of rural.
Thank you for listening to another episode of Rural Health Today, the podcast where we connect you to what really matters in rural health. Rural Health Today is a production of Hillsdale Hospital in Hillsdale, Michigan, and a member of the Health Podcast Network. Our host is JJ Hodshire, our producer is Kirsten Newlon, and our audio engineer is Kenji Ulmer. Special thanks to our guests for sharing their expertise on the show, and also to the Hillsdale Hospital marketing team. If you want to submit a question for us to answer on the podcast or learn more about Rural Health Today, visit ruralhealthtoday.com.